Do you have any like general impressions about the?
I think, for the most part, I think the elderly in our community are pretty well served, I believe, at least the ones that I've encountered. We have a few services available here in Fort Kent. We do have Meals on Wheels for those who qualify, and to be quite honest with you, as far as who qualifies and who doesn't, our office nurse works a lot with that, certainly more than I do. They have the Senior Citizen Center where they have meals for, reduced rates or maybe even free. I'm not 100% sure. A lot of my patients do utilize those services. So, as far as those that are completely underserved, I think in large part, I think that our healthcare providers do very well in finding some sort of service that's of benefit to these patients. Some are on food stamps, depending on, income and so on and so forth. But I mean, I've not run across a huge population that's completely not served at all.
Mm-hmm.
So.
Okay. Maybe you wouldn't see it as much in your practice as, like, say, emergency, but do you...
I actually work in the emergency room, too. So.
Oh, okay.
Yeah.
So that's good. So is that, like, a reason that people enter into these services as they're coming into the ER or being admitted to the hospital because they are...
Like malnutrition and
yeah.
stuff? No, I don't see that a lot. I think in large part the patients that come in with, things like failure to thrive, for example, or dehydration and whatever is usually the result of something else. If it's end-stage disease, whether it's like Alzheimer's disease, for example, where you tend to see, in end-stage Alzheimer's, you tend to see people kind of fade away slowly over time. And it's not necessarily because they don't have the services available, it's a combination of factors, and really the disease progression is what's the underlying etiology there. We do see lots of patients be admitted for dehydration and things like that, but with that said, most of the time that's due to something else. It's due to febrile illness or persistent vomiting or whatever else is going on. I can't say that I see any, I've never seen any hospitalizations on the basis of, look, this patient doesn't have anything to eat or drink.
Okay.
So, yeah.
All right. Do you notice much of a difference? I mean, obviously it's going to be more subtle at this point because we're not seeing real super acute stuff, but
right.
Say someone coming from Allagash, would you think that population is in general more affected by not having as much food in the house because even if they are served by a nurse or Meals on Wheels, they're not going to the grocery store. So
yeah, I think you hit the nail on the head. I'm not sure that they're, and I really hate to generalize, I've never lived in Allagash and I can't tell you for certain, but I think their biggest problem is the distance. They just don't have access to all of the same, well, they have access, but it's 30 miles down the road, to all the same grocery stores and things that we have here. They do have some, little, from what I understand, either convenience stores or grocery stores of type, you might say, out that way. I don't know to what extent those places actually provide them with nutritional food. Unfortunately, a lot of like convenience stores and stuff, they sell all kinds of food, but none of it is really, nutritionally beneficial, if you would say.
Yeah.
A lot of the packaged stuff, processed stuff, high fat, high cholesterol, high sodium, all of that type of thing.
Yeah.
Is usually what you'd find there. And I'm not necessarily, generalizing that towards St. Francis and Allagash. I think that, in general, the more rural you get, the more you run into that.
Mm. Yeah, I mean, you see that even in Paradise versus like a Hannaford downstate, or
and that may very well be true. I mean, I come from here, and so I don't know a lot different.
Yeah.
And with that said, yes, when we vacation in southern Maine, for example, you go to Shaw's, and they get this humongous selection of whatever you want. Whereas I think our stores up here do very well. It's just we simply don't have the need to have a humongous store like they would have in southern Maine, for example.
Do you have in your practice a finger on the pulse of anything going on in home health? You have people that you work with directly that deal in that. So do you ever get any report on them of sort of like a before and after? Like,
I do. I mean, home health services are something that we utilize quite a bit here. In my practice in internal medicine, a lot of my patients are older, and some of them are at end of life. And for those patients, we have either hospice services or home care services, depending on what what point in their life, what their needs are. There are a couple of organizations in the area here, all of whom are super helpful, and the nursing staff from VNA, for example, calls me directly, first name basis. Hey, so and so is not doing so well. He or she's in more pain, or hey, I think this medication might, be giving her too many side effects. Could we consider changing it? I mean, for me as a provider, that's super helpful to have a nurse out there. For these patients who don't have transportation, I think, so I know this is more on like food and nutrition and stuff. I think transportation is a bigger issue for our elderly patients than food is. Because the food can go to them, but transportation doesn't necessarily come easily, and we don't have taxi services and whatever here. So my experience with our home health agencies has been fantastic. It saves my patients from having to come in here every month for me to, keep that finger on the pulse of what's going on with this patient. If they're at end of life, if they're end stage cancer or whatever. I really hate to make these patients travel. Because it's, these are their final days. I want them to be as comfortable at home as they can be if that's what they wish to be. And so having somebody be able to go out and see them is exceptional.
Okay. You kind of touched a little bit on a point that I wanted to see if you had any insight to with the medications and the side effects. Do you, what do you think the polypharmacy might have impact on these people and their eating? Because we've talked about in class is that they're taking 20 pills in the morning, and then food isn't really a priority. So you think that, do you ever, I guess it's your general impression on that, but do you ever look into that when you find maybe you have a patient who's a little underweight and you want to think about doing stuff like that?
Yeah, absolutely. So polypharmacy is a huge concept, and it has its effects on nutrition, among other things, quality of life, side effects, compounding effects, drug-drug interactions, and all these other things that come with taking more than one drug. As far as how it relates to nutrition, I'm not certain. I wouldn't go so far as to say that people are taking their pills instead of eating breakfast. But with that said, the ongoing joke in healthcare is, well, you're not going to be hungry for breakfast, right? You get all these meds. And I say it's a joke. It's really not a joke at all. It's, these patients are on a ton of meds. And personally, I tend to be a provider that likes to manage conditions with as few meds as I can. Because if you look at the literature, man, I'd have to find a statistic for you. And I was in training and it right off the top of my head, but it was like as soon as you get... for every med you added that was greater than 3 or 4, there was a threefold risk in drug-drug interactions and compounding side effects. And don't quote that because I'd have to find the actual statistic, but it's ridiculous. For every med you add, there's an extra threefold risk. Well, we have patients on 20, 25, 30 drugs, depending on what their conditions are. Now, I think up here we have a huge amount of COPD. I like to venture a guess to say that there's a lot of factors that go into that. We are a farming community and have had a lot of patients work their entire lives on farms and be exposed to all kinds of pesticides and different chemicals used on the farms. That may have contributed. Obviously, I don't know that for certain. I haven't done any research on my own, but that may have contributed. Smoking is huge up here. Fortunately, it has gotten a lot less. However, risk factors for COPD, it's one of the first ones we think about. Well, for these patients who are basically on oxygen, let's say they're, end-stage COPD or chronic hypoxia, chronic respiratory failure, they're on oxygen, they're using nebulizers at least every 4 hours. To keep up with all of these things, I might say, look, it takes time, and so these patients don't necessarily take the time to do other stuff, maybe including eating, for example.
Yeah.
I would think that they still eat, but with that said, that's significant.
So when you're referring people to different home health services, is it a pretty? It sounded like you made it seem like it's a pretty easy process, but are there
Yeah,
any
it is.
specific hurdles in terms of funding or anything like that you encounter?
No, not at all, really. I mean, as far as home health, I've not run into any issues, and we have some really good support staff that works out of my office that kind of does all of the hard work in the background. Unfortunately, I can't comment too much on how many hurdles they run into because I don't know. But with that said, my referrals to home health stems from anything, if somebody, even if it's a younger person that is not chronically ill, maybe they had, a huge, major trauma. They had a femur fracture and they're, need services of some kind, whether that's in-home PT/OT or home health for something else, help with ADLs or whatever. Those are reasons that I would refer. As people get older, if they need help for activities of daily living, or if I think that there's a significant risk in their home for falls, if they might benefit from an evaluation to say, hey, you could have handrails installed, you could have ramps, you could have, have us take out the throw rugs or anything that, trip hazards, whatever. Those are all things that home health automatically looks at, which is really nice. They look at the patient's nutrition and they look at the patient's meds and they kind of look at the patient holistically and then can report back to me and say, hey, look, this is what I found. Can you help us with this? And yeah, absolutely.
Okay.
But no, I've not had any major issues getting patients into home health. As far as hospice care is a little different. We do hospice in our community on a limited basis. I mean, I think in large part the hospice patients that we have are typically in the nursing homes because they simply require a higher level of care than home health can provide. I mean, a hospice patient, it won't be sufficient for them to see a nurse once a week. So I think that we do have some in-home hospice arrangements, but it's quite difficult to make it work for the patient and for the organization.
All right. So you have any general thoughts at all about, maybe things like outcomes when you're treating patients, if they're a different body weight or, they come in with a different nutritional status,
Absolutely. So, I mean, as far weight is huge. It is. I think it's something that every healthcare provider rather knows about. But it's one of the most difficult things for us to change, and it's not because necessarily it's not because we don't know how to change it. It's just that it requires a lot of the patient's input and patient's buy-in. And so whether that's because they're underweight or overweight, I guess the problem really is similar. We can start with overweight. So as you're aware, I mean, being overweight increases your risk for all kinds of health problems. Anything. So your typical, the bread and butter internal medicine patient, for example, is going to be overweight, have diabetes, hyperlipidemia, hypertension, and maybe some heart disease, let's say.
Yeah.
That is what we're seeing a lot of. And when you really look at it, if they're overweight, could that have contributed to their diabetes? Of course. Could that have contributed to their heart disease? Yeah, it can. Not necessarily from them having been way too heavy, but how is it that they got there? Was it because they were sedentary? Was it because they ate inappropriately and all of these things? So they ate foods with high cholesterol and poor nutritive value, empty calories. Yeah, that can clog up arteries, cause heart disease. So there are so many conditions that are either brought on by or influenced by being overweight that it's something that we need to focus on. Now, being underweight is a problem in and of itself because, especially in our elderly, being underweight is a higher risk for things like hip fractures and spine fractures and just other injuries if they fall. It's interesting, but being not overweight, but at the high side of normal on your BMI, for example, offers some protection if you fall, especially in our elderly patients who are, have osteoporosis and have all these other problems that increase their risk of serious injury. So for these patients, really dietary counseling and making sure that they have the services that available to them like they should, making sure that they have meals available to them, or that they have support by somebody, and families are huge up here. It's a small community, so families often provide most of the support for these patients, not necessarily always a referral to home health or anything like that. But yeah, I mean, in general, a patient's weight influences everything. And so we do focus on that in healthcare, but there is no magic pill either for being overweight or for being underweight. And so it's really the difficult part of that is getting your patients buy-in, because if nobody wants to walk into the doctor's office and say, I can't help you, you're too overweight, or you're obese, or you're morbidly obese, or whatever. You give all these labels for things, right? Really, those labels mean something. Those labels are tied to research and risk factors based on how high is their BMI. So if their BMI is greater than 40, they're morbidly obese. Greater than 35 with overweight-associated problems, heart disease, for example, what have you, morbidly obese. So these types of things we try to change. We counsel our patients as best we can. With the time that we have with them, try to get them to follow up frequently if we can, if they come in. It's kind of an endless cycle. I think in general Americans eat poorly. Let's face it.
Yep. So you mentioned a little bit about the family. Does you think that might be a factor in the region that kind of makes the whole food supply issue a bit less of an issue? I kind of had that impression too.
Yeah, it's huge. Yeah, I mean, up here especially for the elderly, they're often taken care of by their offspring, their children. If it's not children, it's some other family member. I don't know if that's true. Like I said, I mean, I grew up here. I don't know if that same thing would be true in more urban areas. I would like to think that it is, but with that said, the culture up here supports strong family bonds, I think.
Yeah.
And so, yes, there's no question that family members do help our patients get the services that they need. And oftentimes we delay referrals for extra services because of the support that the family is providing the patient. The family doesn't feel that extra support is needed because, look, all of these things are being taken care of like they ought to be, and I'm fine with that. It saves the patient money, saves the family money, and so long as so long as the patient's being cared for in such a way that all of their needs are being met, then why would I refer?
Okay, that's a good point. So is there anything else that you think that you can think of that might relate to the whole nutritional topic, nutritional and
Well,
elderly?
I mean, I think nutrition ultimately starts in childhood. Nutrition really just has a tremendous impact on everything. You don't have to be overweight to be unhealthy. You don't have to be underweight necessarily to be unhealthy. You can be of a totally normal weight and eat very poorly and have horrible cholesterol or horrible electrolyte balances because your meal intake is terrible. You're just not eating anything of nutritive value, and that starts as a child. And children will eat whatever is given to them. And so, I mean, to an extent, obviously. And so, if you're feeding your kid McDonald's at age 6, that's probably not a good thing. Childhood obesity. So what's interesting, I know it's maybe a little off topic for you, but we used to say type 2 diabetes used to be adult onset diabetes is what we used to call it. Do you think we have type 2 diabetes in anything other than adults?
Oh, yeah.
Of course. We got type 2 diabetes in kids, like, I've seen it as young as 10. I know there's kids younger than this. It's unbelievable. And type 2 diabetes is a problem of insulin resistance. And insulin resistance comes as a result of a number of factors, with probably the strongest factor being extra fat. Fat promotes insulin resistance. Insulin can't work as well. And so it just compounds from there. And, if you got kids with diabetes, man, they're going to have a rough life. By the time they get into their 30s and 40s, maybe their diabetes has continued to worsen, or they've continued to gain weight and their glycemic control has worsened as a result of that. Well, think about end-stage diabetes or later stages, not necessarily end-stage, renal problems, or kidney issues, eye problems, vascular issues, heart problems. There's all kinds of squall out here that come as a result of uncontrolled diabetes, and I think the earlier that starts, as if it's uncorrected, the more problematic this is going to be for people. So, I mean, nutrition is can't be overlooked. And I'm not saying you can't go out and, have a meal in the town or something here at some point. That's perfectly fine. But it's important to remember that that's not an everyday or a twice-a-day thing. I mean, you don't eat McDonald's twice a day and expect to be healthy.
Yeah.
So, but with regards to expenses, it is expensive to eat healthy. Period. Go to the store and take a look. I mean, you can get prepared meals. You can get a frozen pizza for like $4 for a big frozen pizza. You can get the little ones for cheaper than that. How much do you think it's going to cost you to get a fresh garden salad? I mean, you're talking like 3-4 times that price to have a salad that actually is going to have some value to it. Have something in it. So that's a problem, because the people are not a bottomless pit. People don't have necessarily the financial ability to eat healthy all the time and support their families in other ways.
Do you find that a lot of the elderly in this area, especially those that are on, various services, are sustaining themselves on more of that type of stuff? At least according to their reporting to you, is that what they're saying they're eating?
To eat poorly, for example?
Or just like, what do you eat? I'm like, I got like 3 frozen dinners I eat every day.
Yes, I've heard some of that for sure. They eat what's available to them and what's affordable to them. And as far as like the services that we have available here, I think do a pretty good job at having meals that are fairly nutritious, whether it's Meals on Wheels or the Senior Citizen Center or what have you. I think for the patients that don't have those services and simply are on a limited income and trying to sustain on their own, those are the ones that are more likely to be eating, the frozen TV dinners and the whatever else that, just puts food in your stomach, puts calories in your stomach, but really nothing else.
Yeah.
So.
Okay, well, I think we covered a lot, so unless you have anything else that you think would be helpful that you had in your mind.
No, I think that's about all. If you have other questions later, please feel free to...
Yeah, I'll leave you my email, too, in case you want to think of anything you want to send me.